Excellent morning. Happy to see you here. And especially I'm happy because the temperature here is twice higher than in our great city of Philadelphia. So it's great when you go out to jog at 5:30 or sunrise time, much nicer here than elsewhere. So great to see you. I see some faces. I see some of you that grew up and some of us aged at the same time. And happy to share with you the thing that you need to know when you need surgery anesthesia, and share with you a few initiatives that we embark on at Thomas Jefferson University, and I think that they bring a different aspect of hope to the life of every single patient in FOP. So just imagine that you can have a cure for FOP. We leave the room, we'll go out and celebrate. And if not, imagine that we can take what Emma told us when we had the meeting of the physicians and the scientists 2 days ago. I want to keep my mobility. Just imagine. Or access to tools and technology that are going to improve everyone's daily life and living. And we'll talk about it. So what we'll be covering this morning? What you need to know about surgery and anesthesia for the FOP patient and family. How to prepare for this great day that you may have surgery and anesthesia. It's challenging, it's nerve-wracking to any patient, not to say, how about a patient with FOP? So those of us who had surgery know that it's a challenging day. No question when you have FOP and your daily challenges are there. And then someone has to make sure that you fall asleep and wake up safely. It's like in aviation. If you ask a pilot or anesthesiologist, a single word that defines what's important. One word, safety. So what the anesthesiologist that's supposed to carry you in a perioperative trip knows about safety and how to make it safe when he knows nothing or very little about FOP. And at the end, I'll present some of the initiatives that we embarked on at Thomas Jefferson University at the great city of Philadelphia. So what type of anesthesia we have? 3, simple, straightforward. 1, we call it local. When you take the anesthetic, deliver it to a place. You need to take a mole on your skin, you infiltrate it. You need to go into the dentist, and that a tooth treated or extracted, you inject a local. And then you have regional anesthesia. Those who had labor delivery and had needed an epidural, which when it works, I call it happydural. Again, you go in with a needle, and then the labor of delivery is a great time to remember and to savor when you, your loved one, and the baby. But you need 2 things, needles, and then you have the general anesthesia, that you fall asleep and you wake up. If it was great, it was the best sleep of your life, and you had a problem, and the problem has been taken care of. So as I mentioned, and as we know, needles are not recommended for patients with FOP. As I'm a pediatrician and pediatric anesthesiologist, I said, children have allergies to needles. Same thing, FOP patients don't do well with needles because it can cause heterotopic bone formation, well documented. Except few areas. Number 1, dental, we learned, and you hear more of the dental expert, you can infiltrate the area submucosa when you don't go to muscles, and then you have numbness and you can do procedures. So in dental medicine, yes, you can have dental care and without actually causing any damage. You can get subcutaneous injections for immunization, and we know that it can be done, which is very important to be immunized or vaccinated so you don't get flu and other diseases. And every procedure in the operating room, we start an IV. No problems. So we have a rule, and then we have the exceptions because we have coexist and make things happen. So as I mentioned, local anesthetic in regional anesthesia and local have to be taken care of very seriously. But we heard those in a meeting of the scientist and the dentist and the pharmaceutical company of a patient that needed surgery, big surgery of the foot. And they were able to put a block, like numbing a large area of the foot with regional anesthesia, putting a needle and infiltrating it with local anesthesia. But the patient had such an advanced FOP disease, flare-up didn't happen, and the limb was fixed anyhow, and they were able to do the big surgery without any problem. So as you can tell, we try to think outside the box, move the needle, and more important, improve the quality of life with our know-how of anesthesia and surgery. General anesthesia have done so many times, and at Thomas Jefferson University, we've done more than 100 procedures. I want to say 150, but more than 100 patients went through our gates, came in and left out, and I'll talk about it later, and they did extremely well. Not that it was an easy task, but at least we have the system to make the general anesthesia safe, with good track record, and we serve as a center that can advise other places how to conduct or create general anesthesia. And I'll talk about my plan creating centers of excellence or center to care for FOP patients around the globe. So the challenge, there is a need, and like any anesthetic, to take and protect the breathing so we can give enough oxygen, take out the CO2, give the anesthetic, which is given through the anesthesia machine, through breathing. So you have to put a breathing tube. How you put a breathing tube in someone who cannot open the mouth? Big deal. But how about the anesthesia and placing a breathing tube if someone can open the mouth? It's very well documented. We have a young girl living in our neighborhood to Philadelphia, riding a bike, fell, hit her head, had some epidural bleeding, went to the hospital, intubated, neurosurgeon evacuated the wound. She is fine. And she's, again, a young, thriving individual. 3 months later, the jaw was locked. What happened? It was happening because anesthesiologists, during our devices opening the mouth, challenging the temporomandibular joint, placing the breathing tube. She was fine, but it was too much to the temporomandibular joint. And our dental expert know that you cannot stretch too much the temporomandibular joint or any other joint because of the reaction that may develop in a flare-up and beyond. So you need to develop other techniques and technologies, but if you need, then you need an expert anesthesiologist who know how to do it safely. And what we do safely, fiber optically, insert the breathing tube through the nose. It's a whole art, but we do it, and as I mentioned, patient come and leave, had the surgical procedure done, and we move on, and we learn from every encounter how to do it better. So what the anesthesiologist need to know when he comes to you, or you come to him or her, and I say, I need a surgical procedure, and so on. So the information that we give to anesthesiologists is pertinent to any other patient without FOP. The medications that are very potent medication that we give are medication that done with, we administer them very accurately based on patient's weight. And there is a difference when you treat a patient, if, as you can see here, a cute, tiny 10-month-old baby girl, or a mid-30s, very large person. But it's not only the physical part. I can take this cute 10-month-old baby, parent hand it to me, and I go to the operating room, and the baby is happy. A 3 or 4-year-old is not so happy when you're separated from the parents. So you have the physical part, you have the emotional part, and I always tell my patient that recovery from surgery and anesthesia has 3 areas, and we have to work on each one of these areas. Because the recovery is physical, painful, you have side effects, and you have to regain your mobility and welfare. It's emotional, and that's why I always advise if you can do the surgery close to your home. And then the spiritual recovery. So it's more than just the technicality going, having surgery, teeth extraction, or other procedure. So you have to invest before the days of surgery in order to come out well. And the more the anesthesiologist knows about you, we help him to get his job done easier and, as I mentioned, safer. So the usual thing, age, weight, height, because we based our medication on them. Do you have any allergies? We have special attention to major organs, breathing, the heart, like asthma, diabetes, heart problems are important. Tell the surgeon, tell the anesthesiologist. Bring all the medication, including the over-the-counter medication. And did you have previous surgeries? How did it go? Oh, I had nausea and vomiting. It was wonderful, and so on and on and on. Very important, so he can craft the right anesthetic for each one of you. There is no cookbook. It's very personally designed process. And most of the physicians and most of the anesthesiologists have no clue what this means, what is FOP, and what does it mean to be a patient with FOP. So we have to educate them. So when I talk to a surgeon from Virginia, oh, the patient just needs a colonoscopy. We all had colonoscopies or upper endoscopies. 15-minute procedure. I said, how about the anesthesiology? Oh, well, the anesthesiology will see the patient tomorrow. So as I mentioned here, so it's not the anesthesiologist needs, no, has. The anesthesiologist must to see you the day before surgery to learn about it. And I always tell them, call me so we can talk about the anesthesia plan. And I can talk about what you need to know about FOP and anesthesia. And sadly enough, not infrequently, when they hear, they said, great, here are the tickets, the patient will come to visit you in Philadelphia. But the goal is to make sure that they can be done in each location. So as we go to these meetings from time to time, I just met a team from Canada, hi Canada, I called an anesthesiologist, come to the meeting, and we had a special session just for them. Same thing in South Africa, and we had a surgery on a patient, a 16-year-old kid that had a fractured femur. So then a young anesthesiologist did the right thing, he healed its history. So we need to educate them. You have to tell them you can or cannot open the mouth, and if you can, be aware not to harm the temporomandibular joint. You have to tell them that the body doesn't react well to injections. We have to come up with modalities, how to bypass it. And most important, it's not a single person job. It's a team effort. And he or she has to assemble a team to care for you. And that's what we have in Jefferson, as you can see. You, the FOP patient, in a center. And around the center, we have the team. Depends on the problem. The more frequent one, dental oral maxillofacial surgery. And Bob DeCidio is actually the chair of oral maxillofacial surgery. He's the one that creating and crafting innovative technologies how to do dental surgery for patients who cannot open the mouth. And we may have GYN issues, urologic, GI issues. Nursing, important because the nurses actually carry the burden of patient care and coordination. They're a very important component of our team. If there is a need, intensive care, they need to know. Cardiology, and as I mentioned, dentistry, oral maxillofacial surgery, and anesthesia at Jefferson are the most frequent team players in this role. So looking back, what constituted success in our process? So as I mentioned, multidisciplinary effort, which means experts from different fields. Communication, communication, communication. It's very important. Develop unique technique to manage a patient who cannot open the mouth. Plans for what happens if you cannot place a breathing tube. What next? So always we have an option doing a tracheostomy in a room. And I talk with this about the family, and knock on wood or real wood, we never needed it, but it needs to be there as a backup plan. And commitment by the institution. And here's an example. Jimmy is a nurse in our operating room, the surgery that we did before I came here. And I said, Jimmy, what is this? Oh, this is a tracheostomy kit. And another kit, and you can show me. Here's a kit for Dr. Nussbaum. So those who remember the legendary Dr. Nussbaum, who was doing dental surgery and did it with him and published paper for 20 years and more, we have a kit for him. It's built in. The nurses just see. We have surgery on FOP patient, they bring it to the OR. So the system is committed to the welfare of the patient. So how we, the team, prepare for your surgery. So as I mentioned, focusing on airway pulmonary exam, we check the patient. Communication among us, simulate what if, like pre-flight checklist, and how we preparing the waiting area, the operating room and recovery area for the patient with distinct physical needs. What you, the FOP patient, needs to do or prepare for the day in the operating room. So I said, here's a picture of gold winners of the world championship or the Olympics. This is US champions, went home with a gold medal. How you walk with your own gold medal from the surgery and anesthesia on a day that is assigned for your procedure. So these individuals work very hard every hour, every day for many years, preparing the body and the mind for the great day so they can get the gold medal. Same thing for us. What are we doing in order to prepare our body to sustain the stress of the surgery and anesthesia? If I can take two things that are important that you can do every single day, even without needing for surgery anesthesia, just building the stamina, and as I mentioned, the physical, the emotional, and the spiritual on a daily basis, and you do it, because when you wake up in the morning, it's a challenging day. But if you do it consistently and investing in yourself on a day of surgery, you will be the world champions. So walking, moving, singing, talking, using the spirometry every single day. So when the day comes, you don't need anything special. You are prepared. For example, here's a typical patient that came to us more than once, and you can see, because the posture, he cannot push the head back, so we tilt the OR table up to accommodate for the needs. We put many blankets, more blankets, special gel pad under the knees, raise room temperature so he or she can be comfortable, a lot of blankets. That's how we prepare for your surgery. And Dr. Crow is here, and Dr. Clive, and Bob DeCidio, who was here and had to go back. They take off the teeth. So as you can see, in order to make the mouse accessible, this is just for oral surgery, we have to tilt the OR table significantly down. And we have to pad it and make sure that you are protected. And the nursing knows the routine, everybody, and that's how we prepare for you. Yes, I'm an old-fashioned person, so with all due respect to the numbers and the screens, I still need to touch and see a piece of the body of the patient, so I leave the feet or the hands so I can see and touch and feel you during the surgical procedure. Here's one of the machines that we use a fiber optic and look at the screen when we do the nasal fiber optic intubation. When you are asleep and you have your great sleep, you don't have to worry about anything, you are comfortable. We still take special care to your hands and other parts to make sure that they are protected and holding it what we call in a physiologic fashion. A lot of details, but that's what makes it a successful encounter. It doesn't matter which surgical procedure you're undergoing through. Of course, you can bring a friend to the operating room, and many of our pediatric patients coming with friends, so we anesthetize a friend, we anesthetize a patient, start an IV. So we don't start an IV on a child before he or she falling asleep. So they fall asleep with a friend, and then we get the needle and start the anesthesia, fiber optic, and beyond. And of course, when they wake up, and this is Dr. Wernick and one of our residents. So when they wake up, they go to the post-operative period, and you may experience pain. You may experience nausea and vomiting because of the narcotics, opioid that we give you. But with good management, we can take off the pain, we can take away of the nausea and vomiting, and then you wake up to your dream garden, and you can start the post-op recovery period. In 2014, we published a paper with our experience anesthetizing so many patients with FOP. So the world will see, because there were reports here and there that, oh, we anesthetize a patient with FOP. We're doing it almost on a monthly or bi-weekly basis, so we have to tell the story, which is a success. And this paper is available, and whenever I talk to someone, I send them the paper so they can read about the disease and what's the ingredient of the success, trying to make it a great encounter in the operating room. So in 2014, we anesthetized 30 patients, but as you can tell, not few of them, many times, usually for dental procedures. Age 5 years to 64, 2/3 of them were in a pediatric range, children. And unlike many other reports in the literature until then, most of them left home. Well, we advise them to stay overnight in a Ronald McDonald house, friends, family, or a hotel, just to get the peace of mind that if something doesn't fit what they believe or they need some help, they close to the hospital and we can get together. Few with asthma, diabetes, and other medical issues I left overnight just to make sure that the recovery and the usual care of their asthma and diabetes going hand by hand. And when they leave home, really they can do it safely and quietly. So my vision and my dream is to take out this model and bring it out to the world. How we can emulate and duplicate and create the same hub for perioperative care around the globe. And we're creating these hubs. We went out to Brazil, traveled to Cape Town, went to Northern Europe, and beyond. We traveled to Israel, so you can see patients who came to the US. This is just representative, we had many more. And trip that we made with our team to different parts of the world and taught them and shared with them how to do it right. And then we created a center for care, or FOP. But really, if you want to upgrade it to become a center of excellence, which means what you need and what I see here, you need a team leader who is really be there and lead as a physician the team. Develop in-depth knowledge about the disease, the patient knows them, so the patient can call for consultation related to surgery or not related to surgery. And sometimes in certain situations, counseling, the emotional, spiritual part. So this team leader needs to do it. And there are few places that are doing it. As I mentioned, mostly in Philadelphia, at Chow in the West Coast, and other places. But really is providing a space that they can do medical care, surgical care, anesthesiology availability throughout the lifespan of the patient, from pediatric to elderly age. And I wish the center will be multidisciplinary and open 24/7, 365 days a year. It exists in Philadelphia. I wish, and I work hard in support of the IFOPA, try to create it in other places over the globe. Here's an example. 2008, we were in Israel, and this is a young anesthesiologist. Since then, she became a professor. She's the head of the department in a major academic center in Tel Aviv, and she's the head of the Israel Society of Anesthesiology and one of the leaders of the World Anesthesia Society. So I know that the patients in Israel are taken care of, or maybe in Europe, Asia, and beyond. And she is a resource person. So here's the patient, the family, Dr. Nussbaum. History done. We moved forward. Many times I'm called about emergencies of a patient. So I dispatch our helicopter team, I go up to the 15th floor and meet the patients. And this was a patient in a nearby state. A week later, in a car, driving back home, everything was done, no need for surgery and anesthesia. But we have a team, gynecologist, neurosurgeon, general surgeon, internist, to care, advise, take a course, and the patient did well without surgery. So what are the new frontiers? As we know more, we advise and we encourage ourselves and the community to go to areas that we have never traveled before and learn. So we had a couple of young female women that want to become moms. It's not always possible for various reasons, but again, we have a team, we can advise, and there is actually an actual patient, a healthy person, young lady who wants to become a mom, not in the US, and we're working globally trying to make it happen. If it happens, let you know next year. We're holding fingers for her. Intraoperative pain management. We have seen that the patient have challenges with intraoperative pain management. I'm using now ketamine infusion, very detailed, but we, again, developing this new knowledge. Dr. Xiaobing presented really seminal work that's done in California about the know-how, the science of pain at perception in FOP patients. So we educating ourselves to embark on new frontier and new procedures, as you can see here, and embarking on new technologies, 3D printing. So we had a patient that struggled, and we struggled, to find the best therapy because he had recurrent left lower lobe infection. Sometimes you have no choice. You go surgery, you take the left lower lobe, that's it, done. Not an option in FOP patient. So what's going on in his left lower lobe? We have no clue. So I suggested let's do a 3D printout of the chest and the trachea. And we have a Center for Design and Medicine, and it was created. And then I went to meet who is a person, it's a third-year medical student. So of course she was baptized to the FOP community, now she's doing it, and she will write the paper about it, and hopefully bring her for the next year meeting. So what did she do? Well, first we created an FOP model, and you can see, as it tilted, I can see what's going on in the left lung. And this is a typical FOP patient. You can see the bone and the connection, but more important, I can see the lung. So she printed out for me a 130 model of the chest, and I can look inside and see the trachea, the airways. And she printed out a model, and you can see this is Dr. Han. He's a world expert in pulmonary medicine, interventional pulmonary medicine, because we said maybe we'll put a stent, like you put a stent in the coronaries for patient who has obstructed blood vessels that feeds the heart. Maybe we can put a stent in a lower lobe. So he is holding a trachea, real size trachea of a healthy person, and I'm holding a 3D printout of the trachea of our patient. And you can see, here is a normal trachea, and here is a FOP patient. And actually, I'm happy to show it to you. A normal trachea and the airways, and this is our real size FOP patient. It's plastics, but we can see the structure of the airway and educate ourselves how we can chart for this patient the best modality of therapy. 3D printing, first time in the world, FOP patient. And I talked to our peers that do the natural history, and we have access to the studies, and one of the pharmaceutical industries willing to give me 100 CAT scans of FOP patients, and I'll pick up 3 or 5 of them and do 3D printing and see over time what's happening, and I can educate and learn, and we can publish it and say, that's what we have concluded, how will be the next time when we have a patient with respiratory problems, how we can meet these challenges in the best way, because we can hold the trachea, hold the small airways, and come up with the right therapy. I'll finish up with the last initiative. What you see here is the Jefferson logo. And we have a motto that we say, we improve life. So every single employee, Jefferson is now a conglomerate of 18 hospitals, 45,000 employees, big healthcare system. I think in US News and World Report, it was ranked like number 17. And every single employee, every single professor and student and everybody, they know our goal is to improve life. So I said, okay, let's take this logo and expand it to the FOP community. So I created the WHEEL project. We improve life and living of the FOP patients. And it's both supported and sponsored by Thomas Jefferson University and, of course, the IFOPA. And from Thomas Jefferson University, Canberra College of Design, Engineering, Commerce, and the medical school. And very generously, Professor, can you stand up, please? Eric here, Eric Schneider, and he is a professor for Design, Engineering, Commerce that will meet with you, and please meet with him. And he has 3 graduate students that's what we'll do for the next academic year. Listen to the FOP patient using design, out-of-the-box thinking, new materials to improve the life and living of the FOP patient. The WHEEL project, and I'm very excited to launch it. So the idea is, as I mentioned, create new tools that will improve daily life and living of FOP patient by harnessing innovative technologies, design engineering materials, and it involves FOP patients, the professor and students of art, design, and medicine working together to create the tools. One word about the physicians that constitute the know-how that take care of the patient in 14 countries, 6 continents. These are the International Clinical Council physicians, 21 best doctors treating FOP patients. We call it the ICC. And if you saw the clinical guidelines, it came from these physicians. And in this room, we have one of them, Clive Friedman, who represents the dental know-how and the expertise. So I ask you, just imagine you can have a cure for FOP. We are not there yet. But listening to the 2 days of meeting with the scientists, pharmaceutical companies, I think we can see clinical studies that will actually stop the disease. I'm not sure about reversing it. But what is better than stopping the disease in a young child? Taking a pill, or a couple of them, and we will not see the progress. And in between, as I mentioned, definitely you have access to technology and tools to improve the daily living. We are here and we are committed. So as Adam Sherman said, together we will cure FOP, and I thank you very much.